Here. Well, thank you everybody for joining this afternoon's meeting to present and discuss some research that HSR UK has been undertaking as part of a consultation on research ethics and research governance. My name is Kieran Walsh. I'm the Chair of Trustees of Health Services Research UK and an academic at the University of Manchester. I'm sort of chairing, and I'm going to just say a few things by way of introduction, partly about the topic, but also about the arrangements for today's meeting. So Health Services Research UK is an organisation that seeks to provide a kind of collective voice on health services research in the UK. It's a member organisation, so our members are largely university departments and faculties, think tanks, NHS organisations, some research funders and others. And we are there to try and provide a collective voice, but also to encourage communication and to support action across the HSR landscape, bringing together both the users of research and evidence and the producers of research and evidence. We're an independent charity based at offices at the Nuffield Trust in London, and my thanks to our staff, Paul, Rakia and Helen, who've done lots of work to bring together today's meeting. The topic of research governance, research ethics and information governance is one that our member organisations, now many users and attenders at our conferences and others, had definitely made clear had great salience. It was really important to them. And so we embarked about 7 or 8 months ago now on a piece of work to undertake a consultation to try to understand across the community, across funders, NHS, people working in the NHS, people working in academia and others, how these systems work and what might be done to make them work better. And the report that we're publishing today and that we're going to present at this meeting is very much the product of the work on that by a small kind of working group that we set up, drawing in people who are interested in the topic, but particularly of Helen Snooks and Ashra Cannon, both of whom work at the University of Swansea, who've done the great majority of the work on this, on running the consultation and particularly on analysing and analysing the results and writing the report. Rakia Ballo, who's one of our staff at HSR UK, who's done masses of work on it as well, helping to get the report to its production phase and get it published today. My contribution has been to kind of run alongside and try and help see this piece of work make a difference. And in many ways, I think today's meeting is part of that point, that, you know, having published this report, we'd really like it to be helpful to the research community, but also to people working in the NHS, people working in organisations concerned with research ethics and research governance. We'd like it to be helpful to them. So in a moment, I'm going to hand over to Helen Snooks, who is going to present findings from the consultation and explain a bit more about how the consultation was done. And she's going to take about 25 minutes or so to do that. The report, by the way, is published today and is on our website now as we speak. I'm then going to ask Juliette Tizard, who's the Director of Policy and Partnerships at the Health Research Authority, to speak. And she's going to take about 10 or 15 minutes to present some views from the point of view of the HRA on the agenda that we're setting out, and in some ways responding to, but also building on the report and the work that they already have underway. And then we have the rest of the time for some discussion and questions and answers. Now, when I last looked, about 60 or 70 people in this Zoom meeting, the way we will organise that Q&A is that we encourage you to put your hand up, basically in Zoom, if you'd like to ask a question. I'll keep an eye on the participant list, and I'll try and bring people in, roughly speaking, in the order in which they've raised their hands. And we'll draw in answers from Juliette and Helen and Ashra and myself and others, but we'll welcome contributions from everyone who's in the meeting. If it proves really difficult to handle that in terms of the number of questions, what you can also do is put questions into the chat, and my colleagues will keep an eye on the chat and feed in particularly common questions that come up through the chat into our discussion, and we will finish at about 3:30 or a bit before. Lastly, Zoom etiquette type points. Obviously, please leave yourself on mute unless you've actually been brought in to ask a question or make a contribution or whatever. The presentations are being recorded, and the only reason we're doing that is so that we can put them on HSR UK's YouTube channel and make them available to people to view who haven't been able to come to today's meeting. Right, I think we should make a start. Delighted then to hand over to Helen Sooks. Over to you, Helen.
Sorry,
Helen,
thank you.
Yeah.
Thank you, Kieran. And I'm very delighted to be presenting the results of this piece of work that we carried out last year, and that I know that a lot of people who are joining today will have contributed to, and will be very interested to see, I think, what we've managed to do, what the results said, and where we're going from here. So the report is called Making Research Work Better: Ethics and Governance in Health Services Research, Consultation Findings. I'm going to whiz through the background because I don't think we need to dwell on this. I think people that have been working in health services research, either, as Kieran said, producing or using health services research, will know this very well, that we need to produce research findings in a timely manner so that they're relevant to the formation of evidence-based policy and practice. And sometimes we can be criticised for being too slow to do this. But before we can undertake research in NHS settings, there are a bunch of permissions and approvals that need to be in place. So these are research ethics, information governance, and research governance as well. And although structures and processes to gain permissions to undertake research in NHS settings have been in place for a while, they've been developing really over the last 30 years or so. And despite many efforts to streamline these structures and processes, there are quite a lot of concerns that that the regulatory journey for health services research studies can be complex, costly, and quite duplicative, which can cause delay to initiation and completion of studies. So we wanted to gather people's views and experiences on these topics. The scope of this project was we collaborated with the HRA, NIHR, and other partners to put together our questionnaire and to undertake this work. And what we were looking to find out was, in HSR, health services research in the UK, what works well, where the problems are, if any, impact on delivery, any differences that people have noticed during the last 12 months, but really during the COVID pandemic times. And then really importantly, looking forward, we wanted to get people's suggestions for improvement. And these across 3 areas of health services research: research ethics, research governance, and information governance. So we put together a questionnaire, and we used an online consultation survey, which was widely distributed with a request to forward it or cascade it on. So we don't actually have a formal response rate because we don't have a particular distribution list. People could gain access to this survey through others. We sent it to the members of HSR UK and the wider mailing list, and we tweeted, and then we know that people passed it on as well. The survey opened 20th of May last year and closed on the 18th of June. So quite a tight time window, really. And the questionnaire included closed and open questions related to sort of demographics, but more about what people's role was, where they're based, and then our objectives in terms of what I said before, what works well, what problems, and so on, in the 3 areas of research permissions. So firstly, and so that you can get an idea of who responded to this survey, we asked where people mainly worked. So you can see there that we had 252 responses. And the largest category of responder was based in university. And then the NHS and some in both. And then a few were based in other settings, a charity, and so on, as listed here. but by far the largest proportion of our respondents were based in academic settings. So then we wanted to know what people's main role was, and 164 of the 250 people that responded to this were classified themselves as an academic or a researcher. And then 24 as an NHS clinician, 17 as a research administrator, 15 as a research manager, 14 as a clinical academic, and then numbers went down through students and so on. So this gives us an idea of who has responded and whose views and experience we're gathering. So we thought it was important to know what sort of research people were involved in, and people could tick more than one box here. So if you answered this, you may have ticked several boxes. And the most popular method used was interviews or focus groups, and then surveys or questionnaires. And then, quite interestingly, over half of people said they were involved in experimental or quasi-experimental studies. And then over 40% in secondary data analysis, and then observation or ethnography. And then other methods are listed there, but had much fewer people ticking those boxes. And then we asked, so again, we get this background. Who are the participants in your research? In other words, who do you do research on or with? And the largest category by far was patients. Again, you could tick more than one box. So almost 2/3 of people also said NHS staff, half of people said public. And then again, it went much smaller numbers to other non-NHS professionals and so on, down to much smaller numbers. So now we come on to the first question, which relates to our objectives. And we asked what works well in research ethics. And here we coded up our responses in a fairly simplistic manner. This is not in-depth qualitative analysis. We had 250 responses to go through, and coding was quite a painful process. And we used a coding frame which came from the responses as we analysed them. So you can see here that I've put key quotations on the right-hand side and the theme on the left-hand side. And what people liked was that there was one national coordinated system, that it was regarded as robust, thorough, rigorous. Some people did say that the speed was something they liked, and particularly that it had improved, although they did note that that was once your application is submitted. People liked that there was an online virtual process, and some people said there was clarity about approvals required. Some people said that the proportionate review system works, and some people said that staff were helpful. And also 14 people, in fact, made comments saying that the process helps to refine, improve, and shape projects. The availability, the online choice of research ethics committees was popular. And there was this feeling that you can have confidence that ethical standards are met. I won't go through every category, but they're all on there and gives you a flavour. So then the next question was, what problems, if any, have you encountered in the research ethics process? And there were more answers on this question. And at the top of the list was that it can be disproportionate for low-risk studies. And the key quotation here, so many forms and boxes for a simple qualitative study. The next theme that was mentioned was that it can be overly bureaucratic and repetitive, that the form is far too long and there's a lot of duplication. The next category down was that there's a lack of integration of systems. There's a lot of duplication of effort between the various parts of the process. And people, although some people had said in the previous question that speed was improving, here there were a lot of comments about the delays and the length of time required to gain ethical approval. Also, that the process can come up with inconsistent feedback, which is difficult to deal with. There were some comments about some of the requirements of the ethical committee process can result in practices which are actually excluding or even unethical. So this was, for instance, things like requirements for participant information sheets, which can be very long. There was quite a few people mentioned that there was a lack of specialist expertise on particular topics. For instance, palliative care and mental health was mentioned there as well. That availability of help and support was not always easy, and that there are a lot of system changes, and that the committees don't always stick to remit. So we asked then, is there an impact on research delivery? A lot of responses to this question, and by far the top of the list was delays. And a lot of people drew attention to the fact that there can be delays to the research timescale, even though there's no flexibility on funding, which is often on fixed-term contracts. There were quite a lot of comments about how it deters research, and what this one here is about how it inhibits clinicians from doing research. There were many comments about what was seen as inappropriate activities, a waste of time, high workload, and not with really necessary work. So waste of research time on endless form filling, for instance. There were a number of comments about the processes reducing the quality of research. Here's one saying rushed analysis because data arrives too late. There were comments about unable to complete project because funding ran out. So problems with research delivery and performance. Some people relate to this. There were quite a lot of comments about the effects on staff morale. And here's one, and I have not picked out the most extreme comments. This is a typical comment. It now takes up more time than the research itself, sapping the will to live and motivation. There were comments about the cost of all this and the processes, the bureaucratic processes and the ethics processes making research more expensive. Also the difficulty with planning when timelines are very uncertain due to the steps and all the steps in the process. And again, this comment about it can be difficult to have to deal with comments from more than one committee, how to respond to them. So I'm going to move now to this sort of second part of the system, which is research governance. Although I should say that in people's minds, in the responses of people that filled out this survey, there was clearly quite a lot of confusion between what is the research ethics part, what is the research governance part, what is the information governance part. So the questions didn't always stick within, the responses didn't always stick within the question area that we were asking about. And we've just left it where it was, so we didn't alter those. So research governance, what works well? People like the online standardized application form, and people mentioned that staff were helpful. They also were happy with, some people were happy with the robust scrutiny, giving confidence that there are checks in place to keep people safe. Some people drew attention to the fact, responded that the process is clear and this can help think through your project. The importance of local relationships was mentioned by a number of respondents, and that the research governance system can reduce the burden on trusts. I won't go through all of these, but you can see them all on the screen. So when we go on to problems encountered, if any, in research governance, top of the list again, delays. And the key quotation here, lack of transparency, very little input, often having to wait weeks, months to be told we have not submitted the right document. The inflexibility of the process, and the fact that the system is quite fragmented, so sites having different requirements and different forms, and that it's challenging to find the right advice, especially in different settings. Similar to research ethics, there was a lot of people bringing up the fact that the system didn't really fit non-clinical, non-trial study approaches. So overly bureaucratic processes for low-risk qualitative research, because they are tailored to clinical trials and intervention studies. There were quite a number of respondents who reported that staff in research and development departments in trusts were quite risk averse, and that they had a defensive attitude. And then that the process is laborious and there's a requirement to contact and involve multiple people, and that it's not always easy to even know who you should be contacting. And then finally, in this section, that it places unrealistic demands on researchers, and that is a deterrent. So in terms of research governance, what was the impact, if any, on research delivery? And the delays at the top of the list, and delays which actually threaten the volume and quality of research. So delays, delays, delays. This is the biggest message of all from all of this work. It's very bureaucratic and they're very complex processes. So research takes longer and more time is spent on getting approval than doing the work. It discourages research. It's a serious disincentive to conducting research involving patients. And that researcher morale can be affected and it's stressful. So there were fewer categories in this than the research ethics, but those were the categories that came up. So we're going to move on to our third area before we look at the effects of COVID and then suggestions for improvement. So in information governance, we asked what works well. And there were a lot fewer responses in this section, even though we had 252 responses overall. There were a lot more people answering the research ethics and then research governance questions than information governance, which I guess is because a lot of people are putting not applicable in this section. So not everybody is really coming up against information governance, but the people that are responded in this section. And firstly, it was brought up that it's actually that we need a system in place for safety purposes and insurance, so for data protection, and that that information governance staff can be helpful, but they generally have less understanding about the needs of research than other areas of their work. The system is robust and respected. So one person put that the external assurance granted that research has been thoroughly assessed and deemed legal and ethical should not be underestimated. And there were comments about the information governance processes getting clearer and guidance and support getting better and data coverage improving, and that systems were improving. So then we asked what problems had people encountered in information governance, if any. And the top one here was the complicated system, the bureaucracy, the huge amount of red tape in getting access and navigation through data protection. And then lengthy processes and delays. The lead time required to obtain data from NHS Digital precludes a great deal of responsive policy relevant research. A lack of clarity or understanding. Agreements to share data could be very slow and very bureaucratic to get in place. And variations in understanding and requirements, which means that you end up doing different things in different sites. And that the result of all this is that it can be really expensive and not always feasible to carry out. Also that, and I think this went across the board, that you have to have everything set up right at the beginning, so there's very little scope for exploring data sets or methods. And lastly, that there's a lack of integration of systems. So the impact of this on research delivery, again, top of the list, same as the other two areas, delays. And these were reported as massive. Funded projects running years over schedule. Workload, major administrative burden. Project delivery, my funding ran out while I was waiting for the data to arrive, so now I cannot do anything with it. Also, I think that you can see the themes across the areas here. Also, in terms of research methods and quality, the less complete data analysis because time runs out. So massive, massive delays, meaning that investment decisions continue to be made without any information about effectiveness. So this is making it really difficult to produce timely, high quality evidence to inform policy. And costs are very large. So again, this deters people from carrying out research and is stressful. Okay, so across those three areas, I'm just going to we asked questions about, did people notice things had changed during the COVID period? And the answers to this were very varied. So people were saying some stopped, some stops restarted, some required additional paperwork. It was different between areas. In some cases, it was slower and extra delays. In other cases, particularly for non-COVID studies, but even for COVID studies, this part of the system didn't necessarily work well. Sometimes it did, but not always. But going online with things seemed to have been helped a lot, although there was a lack of clarity about how that, with research methods, when they went online, how to get those processes through all the permissions required. And then suggested improvements. I've tried to edit this slide, but it's still really full. And I've pulled this together across the three areas. So although there is supposed to be a single centralized system, this was a suggestion that this still needs to be streamlined to incorporate ethics and governance and to cut out duplication. It was brought up again and again and again that simplification and proportionate review of low-risk studies needs to come into place urgently. So a lot of studies like qualitative work, audit, quality improvements, secondary analysis, these studies can have to go through the whole same process as a clinical trial, for instance. There was some clarity requested, time targets, clearer guidance on how to link with R&D departments. Importantly, I think patient information sheets and consent forms should be simplified because this can actually end up excluding vulnerable groups. There was a point made which was to balance the risks to participants with the risks of not undertaking the research. There is a cost to all these delays in terms of producing evidence, and then to learn from the pragmatic approach taken during the pandemic. So don't really need to go over those again, I don't think. Confusion, lack of clarity, over bureaucratic, duplicative processes, disproportionate, risk averse, perverse effects, delays, costly, stressful, restrictive for research. Sounds like quite a negative list. We did also get some positives, but these were the overriding messages. So we want to use these findings to really try to work with the HRA, and not only the HRA, but other partners, and system-wide, to try to improve things so that we are able to do what we're trying to do, which is provide evidence about health services research, which is timely. We are taking this forward now through this meeting, through publication of the report which has come out today, and we really welcome your views afterwards. I'm going to pass over now to Juliet, but first I'll just say thank you to everyone who contributed data and experiences to our 2021 consultation. Thank you.
That was great, Helen. Thank you very much. And there's a huge amount of detail there, and there's even more detail in the report that people can find on our website. So yeah, we're going to hand over now to Juliet for her to talk about the findings and the work that's going on at the HRA. And I would say Helen and I presented and discussed this with HRA's executive team last week, and they were lovely. They were so welcoming and really enthusiastic, and it's clear that, you know, there is a very powerful shared agenda here for improvement. So Juliet, over to you.
Thanks, Kieran, and thanks very much, Helen, for that presentation. Thanks for inviting me today to give my reflections on the report. As Kieran said, I'm one of the directors at the Health Research Authority, and for those of you who don't know, I'm sure you all do, that the HRA's purpose is to protect and promote the interests of patients and the public in health and social care research. And just to give you a little flavour of sort of what I do in the organisation, I've worked in health policy and medical ethics for quite a few years, and since I've been at the HRA, I've been leading on some of our work around improving research practice. So particularly in research transparency, our Make It Public strategy, which is aiming to make research more visible to the public and to participants, and our work around sort of embedding good practice around public involvement in research as well, which I know is very dear to your heart too. I'm also leading on a piece of work called Think Ethics, which is focused on making research more ethical, but also making research ethics review better. So I'll tell you a little bit more about that in a moment, because I think you'll be interested in some of the work we're doing there, because it chimes very much with the findings of this report. So it's really good to hear this. It's tough reading for those of us who work at the HRA, but I think is really keen to come along today, not just to hear again the Helen's summary of the findings, but to listen to the discussion that you have this afternoon, and for that to be a sort of hopefully the first of many to come. So I'm here to listen, and that discussion would be very useful to us. I hope you'll be reassured to know that many of the findings of the research are familiar to us. They chime with our experience. You can't really administer a regulatory system without being aware of its current shortcomings. I think it ought to be concerning to you if we didn't. But this survey is really useful to us to give us greater insight into how the system is being experienced by particular types of researchers, obviously health services researchers in this instance. And it's very useful to hear about those individual experiences and the suggestions for change as well, which are very much welcomed. I just wanted to touch on three aspects of the findings that struck me. Then perhaps talk about how we think they'd be useful to some of the improvement work that we've got underway that Kieran mentioned, and then before sort of suggesting how we might work together in the future. So I suppose the things that struck me, I mean, I think there are lots of useful things in here, both in terms of the work that we're leading on at the HRA across our different functions, but also the work that we do in kind of influencing across the system. We've got a role to facilitate and coordinate research across the UK research landscape. So I think where we're sort of have more of an influencing role than a leading role, this is also really, really valuable insight as well. So I suppose other colleagues working on those areas might draw out different things, but I just wanted to look more at the research ethics ones, because that's an area that I'm sort of working most on at the moment. I suppose the first thing is I was struck by the value that people place in ethics review. And comments about the improvements that have been made. And I'm not picking that just because it's sort of human nature to lean towards the minority of positive comments in what's otherwise quite an avalanche of frustration. But I think because it's important to value what we have that we want to hold on to, and in thinking about what needs to change and how we can improve and modernize, that we retain what works and that we understand why that works and do more of it. The second area I think that really hit home for me was the comments about ethics committees. I think both in terms of how some of the people's experiences of how they behave and also what they focus on. I think I was probably most struck by the comment is, our PPI asked us to reduce the length of our consent form in one study. The committee refused. This sent a very bad message back about the role of PPI. which I agree with. The whole point of involving people with relevant lived experience in the design of studies is to make that study more relevant and acceptable to the people who are likely to take part in it. So RECs should be taking assurance from public involvement. And, you know, they do, but they clearly don't do that universally. And we really want to make that normal practice. So they shouldn't be there really to second guess or redo what's been done, but take assurance from good public involvement that's already happened before the study comes to be reviewed. So I think that really hit home to me, and that's quite a big area of work. I haven't got time to talk about it today, but it's quite a big area of work for us in Think Ethics around how committees make decisions and how they approach and how the kind of ethical issues and how they balance them, what's important to focus on and what's for other people to be concerned about. And then the third area, I suppose, that you couldn't fail to be hit by was the sort of sheer frustration of navigating the system and the fact that some people want to avoid it altogether. I think the quote that said, "We've avoided setting up studies, compromised on our sampling strategies, and generally been discouraged. The feeling is that HRA should be avoided if at all possible." I hated reading that bit, because, you know, not because I can't take criticism or we can't take criticism, of course, but just because our staff are there, you know, we come to work because we want research to thrive and we want good research to happen and be open, and there'll be opportunity for lots of people to get involved in that, and for us as a society to reap the benefits from that evidence that's generated. So we're not here to get in the way, we're here to help, and we, you know, that's good motivating feedback for us to remind ourselves that you know, what we do has an impact on others, and we want to make sure that experience is as good as possible. So I suppose those are the kind of three things that I took from the survey. I just wanted to touch a bit on how they might be useful to us in the work we're doing around ethics review. So we launched the Think Ethics programme back in the autumn, but we've been working with an advisory group probably since the summer last year. And they've been helping us to sort of shape the work and prioritise what we do. And the aim of it really is to make research ethics review more efficient, more innovative, without losing that important public trust in the system. And a big part of that is about making ethics review better, you know, more proportionate, more consistent, focusing less on some things and perhaps paying more attention to others that are a bit neglected at the moment. But I think it's also importantly, which is why we use the title Think Ethics, it's about helping to encourage ethical thinking much earlier in the process, so that we can perhaps get to a situation where ethics is seen less of a hurdle, or indeed something to try and avoid altogether, but something that's, you know, universally felt as something which is beneficial and helpful to research. So I don't have the time to talk about all of the things we're doing in that programme, but I just wanted to, and I'll put a link in the chat afterwards if that's okay, to the kind of wider reading around the programme. So I just wanted to pick out one area which is around proportionality, which I think's come out a lot in the findings of this survey. So as you know that we've got a proportionate review process, which reviews about 30% of studies. The other 70% are reviewed by full ethics committees. And the proportionate review system is done out of full committee, usually by a couple of research ethics committees in correspondence. And I'm guessing quite a lot of health services research goes through that pathway. And we know that we could take a much more proportionate approach to reviewing certain types of research. And some of the research that's currently reviewed in an ethics committee could be reviewed outside of a formal ethics committee. And benefit of that, you know, I'm sure the obvious, the benefit for researchers, but it's also beneficial to ethics committees and for us, so we can focus them on the stuff that really warrants their close scrutiny. And we think there's a greater role probably for expert staff to take part in reviews of certain types of research. But we're also thinking at this point, about developing some different pathways for review. So that might be, as I said, a sort of greater role for staff in doing more kind of proportionate reviews of lower risk studies, or studies with fewer ethical issues, should I say. But also looking at maybe some kind of institutional level review, kind of like a devolved review, if you like, perhaps through an accreditation scheme, or maybe some element of researcher self-assessment as well. So we're working on these ideas at the moment, and we'll be testing those with stakeholders, and I hope you'll be involved in that over the coming months, with a view to consulting more widely later this year. But I think I just wanted to end by thinking about what are some of the things we need to bear in mind when we're thinking about developing new pathways or different pathways for review. So I suppose, there are obvious ones like, are they going to save time to the researcher? So can you have fewer touch points with us as a regulator? So the kind of what we call the administration burden of the process is as light as it can be. Can it shorten overall timelines for approval? Speed is obviously an issue in this area of research. But also, if I'm honest, could it cost us less? Less time for ethics committee members, but less time for us to administer those kind of structures. I think for us, given our role, the crucial question is, would the change be something that the public supports, and therefore overall trust in the regulatory system is maintained or even enhanced? And I think for us, that's kind of the key to some of this, because I think we'd all agree that trust in the regulation of medical research is really important, health and social care research, and that when people trust the system, they're more likely to trust its outputs, the vaccines, the treatments, the devices, the insights, the evidence that it generates, and they're more likely to want to take part and recommend that to friends and family to do so. And trust takes a long time to build and can be lost in a moment. So it's something we're all kind of got our eye on. And we know, a lot about what builds trust and maintains trust in regulation. Visibility and transparency, accountability of regulatory bodies, an opportunity to be involved, showing our working, opening ourselves up to greater involvement for a wider range of stakeholders. And obviously the things like, using public money well and acting fairly and all those kinds of important considerations. And I've seen some of that play out quite recently in a piece of research that we've done since Christmas. We've been doing a public dialogue exercise where we've recruited a cross-section of the UK public to join a process where they share with us their thoughts about ethical research and what's important to them, who they trust, what they care about. And the research company that we commissioned to do it has told me that I wasn't really allowed to talk about it today, so I have to promise not to tell anyone. But no, just to that I'm just going on what I observed from joining a couple of the workshops. They're doing the analysis at the moment. But I think what really struck me is that people are both very principled and they're very pragmatic as well, is the impression I got. They seem to be, capable of seeing the difference between a vaccine trial and, maybe a study using tissue that's already been obtained through standard care. They can see that a differential approach is warranted, and that they feel differently about the kind of what review is needed and who should be looking at research. So although they felt quite concerned when going into the dialogue exercise, the more they learned about how research is done and how research is reviewed, the more comfortable they felt with taking different approaches, because they could see the prize, which is good ethical research starting up quickly and producing findings quickly. So I wanted to mention that because by talking about public trust, I suppose I'm not saying let's do nothing. We have to have the most robust, most careful, oversight and scrutiny. That's not what I'm saying. And I think it wouldn't be right, and it's probably not what the public wants, because they can see there's a balance to be struck between the two. But just to say that, that's the considerations we're going to need to make. And I hope very much that you want to be part of that, of finding the right balance depending on the research in hand. So I suppose just to say that, we really welcome the report. We, like you, want to improve the system. Sometimes it's about developing new approaches and changing policies, but it's also about, making what we've got better. So I think there'll be lots of different solutions to this particular problem, but I do think we can make change, and we're quite determined to do that. And I hope very much you'll join us and help us to shape that future. Thank you very much.
That was great, Juliet. Thank you very much for that. And I'd pick on something you said sort of in the middle of that about no one sort of, you know, goes to work in the morning thinking, I want to stop good research happening. We all have the same interests at heart, and it's sometimes, I think, the system that somehow seems to pitch us against each other and create some of the frustrations that you alluded to. The other thing you said, which I think is, but before I just carry on, I'm looking for questions appearing in the participant list. So now's your chance to stick your hand up if you had something you wanted to ask. But the other point I was going to make, Juliet, was this idea that HRA is responsible for one part of the system, but seeks to influence the larger system. And actually, when I think as a researcher about that larger system, it's HRA, but it's the research funders who, of course, review these research projects. They put them out to peer review. They should have a view, perhaps, about the ethical implications of the research that they choose to fund. There's that bit of it. There's the higher education institutions where we all work, who frequently, because something's going into the NHS ethics and governance system, have their own systems of pre-review. And of course, there's NHS organisations where the research takes place. So it's a complex problem, which is, I think, why, you know, we've had at least 2 or 3 decades of all sorts of people having a look at this system and trying to understand how it might be improved. So at the moment, I've only got one hand up, so I'm going to go to